Good afternoon and good morning also to everyone. My name is Alessandra Aresu and I'm the Knowledge Management and Learning Coordinator of the project Bridge the Gap 2. Bridge the Gap 2 is a project funded by the European Union and it is coordinated by FIAT, the International Ibero-American Foundation for Administration and Public Policies, in partnership with 3 European agencies for development cooperation, the Spanish, the Italian and the Austrian, and 2 international NGOs, the European Disability Forum and the International Disability and Development Consortium. Bridge the Gap is a targeted thematic response to the requirement to make development cooperation accessible to and inclusive of persons with disabilities, with an obligation for the European Union and Member States as parties to the Convention on the Rights of Persons with Disabilities, and which can have a significant impact in improving the social inclusion and promoting the rights of persons with disabilities. Bridge the Gap supports the mainstreaming of disability in international cooperation and the efforts of 5 partner countries, Burkina Faso, Ecuador, Ethiopia, Paraguay, and Sudan, in planning and implementing inclusive public policies and services. Today, the 9th session of this webinar-based training cycle organized by Bridge the Gap, which from the beginning is exploring different topics involving international experts. The webinars are conducted, as you know now well, in English, French, and Spanish in separate sessions. You can find all the previous recordings on our website, on the Facebook and Twitter pages, and on our YouTube channel. You can find the links to these pages here in the chat box in a while. The 9th session today is about access to health, the inclusion of persons with disability in health services according to the CRPD, Article 25. Persons with disability are vulnerable to exclusion and accessing their rights to health. They commonly face stigma and discrimination, violation of rights, lack of adequately targeted and accessible health services, exclusion in access to water and sanitation, and other health determinants, and have lower income levels, which can all increase their vulnerability to diseases. The 2030 Agenda considers disability in 5 goals and 7 targets, including commitments in relation to disaggregating data on disability. The emphasis on ensuring no one is excluded is crucial to the health goal, ensure healthy lives and promote well-being for all at all ages, and this certainly is also evident in the inclusion of the universal health coverage target. To attain health-related targets, the priority must be given to strengthening and making more equitable health system and addressing gaps in geographical and key population groups coverage. States are obliged to respect, protect, and fulfill the rights to health. Persons with disabilities are protected by the same general framework of the right to health as everybody else. However, the international human rights system pays little attention to their health needs until the adoption of the Convention on the Rights of Persons with Disabilities. The Convention on the Rights of Persons with Disabilities shifts from medical and paternalistic approaches to disability towards a human rights-based approach, which considers persons with disability as rights holders rather than as mere recipients of protection, rehabilitation, or welfare. This session today will provide a general overview of the health status of persons with disability and of different topics related to health of persons with disability, such as access to health according to the CRPD, health care needs of persons with disability, barriers in accessing to free and affordable general and disability-specific health care services. Well, I'm not taking more time. I will give immediately the floor to our speaker today, Alessandra Aresu. Alessandra, she currently works at Humanity and Inclusion, formerly Handicap International, as Inclusive Health Policy Lead. Before taking on this global position, she worked as Country Director of the HI China Program 2013-2017. From this position, she led HI's action at country level on sexual and reproductive health and rights, mental health, gender-based violence, and rehabilitation. Prior to 2013, she worked as a postdoctoral research fellow and advisor on SRHR, GBV, and comprehensive sexuality education for INGOs, UN agencies, and academic institutions in Italy, Haiti, China, and UK. She's the author of several articles and book chapters on these topics. Alessandra is also the co-chair of the IDDC Inclusive Health Task Group and of the core group's Disability Inclusive Health Technical Advisory Group. Well, a lot of really international experts on this topic. Thank you very much, Alessandra. It's really a pleasure having you today. I give you the floor in a while, but just before starting, I would like to inform you that, as usual, the webinar is live captioned, and you can follow the transcription of the webinar by linking in the on the link in the chat box that I'm putting in a while. Well, thank you very much, Alessandra. I give you the floor, and to everybody, enjoy the session. Thank you very much.
Thank you, Alessia, and good morning, good afternoon, everybody. It's a pleasure for me to be contributing to bridging the gap training and to be able to speak about access to health and disability and inclusion. I know that some of you have already been learning about disability and inclusion in relation to other topics, not necessarily specifically in relation to health. Other may be more experts on health and less on disabilities. So my choice as a start is to give a brief introduction of what disability means and which are the main key concepts we are going to refer to during this webinar, and then dive into a more specific discussion on access to health. So I would start with the reference to how discussions to disability about disability have been changing throughout the years, and how during the last few decades the approach to disability has changed. And if you see this first slide, the first three approaches that we can refer to are the charitable, the medical, and the social model that are highlighted here. Now, instead of telling you and summarizing you what does it mean, charitable model, medical model, or social model, I would like to use the words of some of the people that we have interviewed throughout the years and that have referred to disability following a little bit these models. So when we discuss about charitable models, usually we talk about people with disabilities that are considered poor and helpless. And in fact, one of the person we have been discussing with about disability expressed her opinion about disability, people with disabilities in these terms, saying people with disabilities are poor and helpless. We need to put money aside to help them. They are a burden for society. And with this approach, of course, the persons with disabilities are far away from being considered full active members of society. And this approach clearly is a barrier towards a full inclusion of people with disabilities. The medical model, however, is also a model that does not support the full inclusion of people with disabilities in societies, because as one of our contributors shared, we see that numbers of people amputated because of road accidents are on the rise. That's a terrible problem because we don't have enough prosthetics for everyone. So if we look at the medical model from this, at the disability from this perspective, we only focus on the impairment of the person, having one leg, being amputated, having one arm, not being not having a full body or a full mind functioning according to the standard that we are used to. And these models, the charity models and the medical model, have been widespread for a long time. When we look at the social model, however, we look at the model that looks not only at the impairment per se and at the status of person with disability in relation to his or her health, but also it looks at the overall context and the environment and the where the person lives. And to give you another quote, a neighbor of a person with disabilities shared with us, yesterday my neighbor went to register her child at primary school. She was very disappointed to realize that the director, who did not have time, gave her all information on a printed leaflet and did not explain anything verbally. My neighbor is blind. That means that the environment around the person was not offering communication tools that were adjusted to the person, in this case, a person with disabilities with visual impairments, visual disabilities. And in this case, the environment was represented a huge barriers to access information that would have been easily understandable for the person if the communication tools were adapted. So this is just to say that throughout the years, a lot has been changing in the way we have been discussing disability. And the reason why I'm mentioning them is because, of course, the way we look at disability and the way persons with disabilities are perceived do make a difference when we want to promote the right of people with disabilities, and we want to, in this case, promote the right to health of people with disabilities. Now, throughout the years, a fourth element comes into the picture. This is more recent, but is essential for the work that we are going to do, for the topic that we are going to discuss today, and is, of course, the rights-based approach. Throughout the years, people with disabilities have organized themselves more and more. The disability movement is present in every country, and disabled persons organizations are active at country, regional and international level to advocate for the rights and to implement projects, that implement actions that are oriented in being fully included in the society. Globally, disability is increasingly discussed from a human rights perspective. And of course, the key tool that we have in our hands when we talk about the rights of persons with disabilities is the United Nations Convention on the Rights of Persons with Disabilities that is dated 2006, and since 2006 accompany us in all the work we do, no matter if we work on health or in education or in any other area. Now, this is the definition that the United Nations Conventions on the Rights of Persons with Disabilities offer us of disability. And it is a very important definition because not only explicitly mention that the disabilities refer to different type of impairments, no matter if they are physical, mental, intellectual, or sensory, but also that when we discuss about disabilities, it is essential to consider the interaction between the impairments and the different barriers that the overall society and environment are putting in front of people with disabilities, and that prevent them to fully realize their rights. This is also the definition that in international law is the one that is now used. And all of us that work in the field of disability and inclusion encourage highly this definition as the one that should be used every time we discuss disability, no matter which is the work that you do. Jumping into the health and diving in a little bit more on health, it is important to say that among the many articles of the CRPD, Article 25 is fully dedicated to health. And it is important to highlight this because the article, and you will see in the next this slide and the next one, really highlights the key elements related to the rights to health. Not only the commitment of the states that have signed, the state parties that have signed the convention, but also which are really the responsibilities of the state parties. Knowing that when we talk about health, we talk not only about health services in general, but specifically also rehabilitation services. So this is a very important moment to highlight that rehabilitation is part of health. And I'm highlighting this because many actors working in the global health sector have for a long time considered rehabilitation somehow an appendix, somehow an external element that was only defined and discussed separately, but in fact, rehabilitation is part of health. And health, when we talk about inclusive health and when we talk about access to health, it is essential to remember that rehabilitation is an essential part of health. Now, when the CRPD refers to the rights for people with disabilities to access health information and services, it also remind us what does it mean, real access to health. And first of all, it means that people with disability has the right to access free or affordable health services in the same way people without disabilities are accessing it. And it is important because, as you know, when many people with disabilities in many countries, especially in developing countries, suffers from lack of opportunities to employment, and very often people with disabilities in the world are among the poorest, and having to pay for services related to health means automatically being excluded by the access to the access to health. So free and affordable is a key element. Another point important to be highlighted is that the convention goes out of its way to highlight very much that sexual and reproductive health services needs to be included in the overall access to health and rights to health. And one of the reasons why this is highlighted is because for many years sexual and reproductive health and rights have not been discussed as a high priority for people with disabilities. And the reason why this was happening is because for a long time, people with disabilities have been considered, have not been considered subjects of sexual rights. But instead, people who need to be protected and people who have no sexual desire, sexual needs. Therefore, with this perspective in relation to people with disabilities and their sexual and reproductive health and sexual reproductive life, very often access to sexual and reproductive health services have been considered a non-priority for people with disabilities. In the last 10 years, you will see an increasing number of actions directed in to promote the rights of people with disabilities in the field of sexual and reproductive health. I will say a little bit more about this topic later when we come to analyze the data we have available on health in relation to persons with disabilities. Other key elements of this Article 25, briefly to refer to the fact that not only people with disabilities have the right to access health services that are general health services that are common needs of everybody, but also specific services that they really need linked to their disability. And this is as important. And another very important element is related to the fact that very often the majority of people with disabilities live in rural areas in developing countries, and therefore it is important that these services, those services that we will call in the rest of the discussion as inclusive services, are close to the communities where people live. And because especially for people with disabilities, if we are talking about physical disabilities, transportation can be transportation and mobility can be an issue, and not only because some of the transportation services are not available, but also because they may cost money, that and therefore the issue of affordability comes back to us. The quality of the services need to be the same as the one provided to others. And another key important point is not only persons with disabilities have the right to access to services, but the CRPD clearly highlight the importance of non-discrimination against persons with disabilities in the insurance sector, because very often we have people with disabilities who, because of their conditions, are not denied a certain type of insurance or asked very high coverages prices. So this is also, the insurance element is extremely important. Together with this, refusing, of course, medical care and services is obviously need to be prevented and prohibited. But and you may be surprised to find so explicitly this element in the CRPD. But if you work a little bit in the field of health and disability, you may find out that often the discrimination against people with disabilities in access to health services is more common than what you may imagine. I will now move on and show you a little bit more about what is the situation of persons with disabilities in relation to access to quality health information and services, and the barriers that we usually discuss and that persons with disabilities face when accessing quality health information and services. And I stress the importance of information and services here, because lack of access of information automatically prevent the access to the services per se, so cannot be forgotten. What to highlight in this slide, that first of all, we have to remember how many people with disabilities are in the world. According to WHO, between 15 and 20% of the population has a disability or lives with multiple disabilities, and 80% live in a developing country. I would like you to keep this data in mind, specifically because when we will come to discuss how to achieve the SDGs and specifically SDG 3 on access to health, these figures will be extremely relevant in discussing how the limited access to health of people with disabilities can limit the achievement of goal number SDG number 3. But staying on the barriers and the status of health and access to health information and services of persons with disabilities, we know from WHO that at least that persons with disabilities are at least 2 times more likely to find healthcare provider skills and facilities inadequate. 3 times more likely to be denied healthcare, 4 times more likely to be treated badly in healthcare facilities. And we also know that more than 50% of people with disabilities in the world cannot afford healthcare. And more than 50% of people with disabilities have an unmet need for rehabilitation. These data come from the World Report on Disability, and that was now it is a few years old. So additional information are provided by the United Nations flagship report on disability and development that was published at the end of 2018. And these additional data tell us that today only 6 countries have explicit laws that guarantee access to healthcare to people with disabilities. And if we look at the data that the survey has produced, the most recent surveys on access to health for persons with disabilities have produced, we discovered that 42% of people with disabilities perceive their health being poor. Versus only 6% of people without disabilities perceiving their health being poor. We also know that the percentage of people with disabilities who perceive their health as poor goes up to 80% in countries with the lowest GDP and goes down to 20% in countries with a high GDP. So this tells us something that is very important when we discuss about access to health and inclusive health, that the income and the being rich or being poor and being a person with disability, the interaction between these two elements highly affect access to health, especially in countries where the universal health coverage is not in practice, especially where there is not a welfare, especially where insurances are needed to have access to health. And this is a key element because poverty and disability and health here are really tied together. The flagship report also tell us something, very initial data on gender disaggregated data on access to health and of women with disabilities, but it's very, very limited. In fact, women with disabilities, we are told, are 3 times more likely to have unmet needs for healthcare than men without disabilities, and the women with intellectual disabilities and those living in rural areas are among the most disadvantaged. Now, here I want to take the chance to highlight the importance of this data, but also the lack of gender, age, and disability disaggregated data when it comes to access to health. In fact, the entire report doesn't offer much more than what I summarized in these slides in relation to gender, health, and disability, and is highlighted that the need for disaggregated data is an urgent need because, in fact, there are several research, several studies, a lot of data on women and health. There are increasing number of data on disability and health, but when it comes to gender and disability and health, the intersection is not explored enough. Therefore, we are not fully aware of which kind of health needs women with disabilities, which kind of health needs remains unmet when it comes to women and girls with disabilities. And this is one of the first barriers that of course, we face when we want to then design services that fully meet their needs. when we talk about women and girls, of course, our mind often goes back to the topic of sexual and reproductive health and rights, which is one of the top priorities discussed when it comes to women. And it is important to highlight that when you are a woman and with disability in a developing country, living in a situation of poverty, access to sexual and reproductive health is limited, and often women with disabilities who are pregnant have less access to maternal health services and informations, and this obviously can affect the health of the mother and therefore of the child. But it may surprise you to know that up to today, we do not know how many women with disabilities have currently are currently assessing the overall services related to maternal health, because disaggregated data on disability and maternal health are very rare. And this is just one of the examples that I wanted to bring you to make sure you understand what I mean when I talk about lack of data. All of this, I have to be brief. I could speak more about the situation in different countries. I'm happy to do so if the data we have available can give us some answers. But all of this, of course, somehow clashes with what we define, or what the WHO has defined as health. That is, of course, as a reminder, a state of complete physical, mental, and social well-being. When we have limited or no access to health information and services, when we face barriers to access information and services related to health, it's very difficult to ensure a full social, physical, mental, and social well-being. And this is, it's always important to go back to the original definition when we want to, when we have an objective that we want to reach. And when we talk about objectives and goals, of course, we can talk endlessly about the SDG 3 and how it is important to achieve SDG 3, and how working on inclusive health and access to health for all, including people with disabilities, will be important to achieve SDG 3. This slide I want to share with you, summarize a little bit the information that I share with you on the status of people with disabilities in relation to health. It is eye-catching because it has numbers instead of words, many more numbers than words, and also that because it also gives you the highlights the importance at the very bottom of the slide on the importance of some of the barriers that people with disabilities face. One of them is physical barriers that need to be removed when it comes to accessing services. Services may be offered by clinics that do not have a ramp. If a person in a wheelchair wants to access those services, has no opportunity to enter. Services may be offered at a high price that cannot be affordable. But also, services can be offered, information can be offered in formats that are not accessible for people who have visual disabilities or hearing disabilities, or simplified information need to be delivered when we talk about persons with intellectual and developmental disabilities. So I share this with you because I think it's good to have it next to you when you are working on health, to remind yourself which are the barriers and the difficulties. This slide doesn't talk about one aspect that is also important to highlight, that is gender-based violence. That is, of course, related to health and goes beyond health, but it's important to bring it into this discussion because not only victims of gender-based violence can develop an impairment and a disability as a result of abuse and maltreatment, but also because gender-based violence is one of those aspects that affect access to health overall. And as for the cases of access to health information and services, not only people with disabilities are much more exposed and vulnerable to gender-based violence, both as adults and as children, but also have limited access to the basic services related to gender-based violence. And this is an element that also needs to be brought into the discussion when we talk about access to health. So the question now is why? Why the situation is so difficult? Why so many barriers faced by people with disabilities? It is important to ask why, because that is the first step towards finding solutions or to improve the work we are doing when we discuss about access to health. This list of these points are not, of course, are limited and only highlight some of the points that I want to highlight to discuss with you, but of course there are many others. However, one of the main reasons why people with disabilities have difficulties in accessing health services and information is, of course, because at the country level, in many countries, health policies are not disability inclusive. And we know that when disability and inclusion is not fully included and explicitly included in our policies, it is very difficult for the services to be offered and implemented in an inclusive way. And that changes in policies is really one of the important steps that we always have to consider when we discuss about access to health. As I said, services are often not inclusive. What does it mean in reality? It means that the majority of health providers are not trained on disability and inclusion. And this means that they can have some attitudinal, they can become a barrier for people with disabilities to access the services, no matter if the service is available or even if the service is available in the area where they live. I'll give you an example. Going back to the sexual and reproductive health issue, many people have been convinced for so many years that, as we say, people with disabilities are not subject of sexual rights, and they are not sexually active. They cannot get pregnant or have children, or if they do, is because of the result of violence, because nobody would be attracted by a person with disability. All these ideas and create a discriminative attitude towards women and men with disabilities who go and look for sexual and reproductive health information and services. And if we do not train our service providers to look at people with disabilities as everybody else, any other customer, any other client, any other patient that is looking for services, the result is that they will be, the needs of people with disabilities will be ignored, overlooked, or that simply the request for services will be denied. And This is why it's so important to invest in training of health providers around the world. And this can be done in many ways. We can discuss about this later, but really, in addition to the policymakers level, the service provision level is the second level we need to focus our attention on when we discuss about disability and inclusion and access to health. Because of course, when health systems are not inclusive, access to health for all is not translated into practice. We also mentioned the limited disaggregated data available so far. And if we do not have data, food for advocacy, we don't have food for advocacy on disability inclusive health to push our agenda on inclusive health with the policymakers. So the data remain a crucial element that we need to keep in mind. And we also have to look beyond the work that we do on disability and health, that people like myself do on disability inclusive health, and look at what, for example, the international NGOs, what we call the mainstream international NGOs, do on to promote access to health for all in an inclusive way. And if you look closely, you will find out that the majority of the major global health interventions implemented today by major NGOs are not disability inclusive. Sometimes because of the lack of disability disaggregated data, they do not even know if they are reaching people with disabilities or not. But in most of the cases, because people with disabilities are living in remote areas, they are difficult to reach, they are sometimes not looking for services because their demand has been frustrated in the past. They are not easily to reach, and the result is that they are left behind. Why this happens? We know there is so much funds on global health right now out there offered by major donors, and that global health is one of the key areas where we work. And well, the lack of major interventions on global health that are inclusive goes hand in hand with the lack of funds fully dedicated to inclusive health when it comes to access to health for persons with disabilities. And I'm saying this because if you look as an example of how do I explain my statement, is that if you look at the major call for proposals that donors put out, major donors put out regularly on global health, we realize that disability and inclusion are not always explicitly mentioned, and is not listed among the essential requirements that the implementers of the project include people with disabilities. So these are some of the why, and there are some of the elements that it is important to keep in mind when we discuss access to health and disability inclusion. I will, at the end of the presentation, I will also make sure that I give you a couple of hints and recommendations about how we can work on the whys and step forward to improve a little bit the situation. This is just a reminder, but we already mentioned it. The Sustainable Development Goal number 3 is our goal and is our element together with the Article 25 of the CRPD. We work hand in hand with the mainstream organizations that are working on global health to achieve goal number 3, and how partnership between disability-focused actors and global health, mainstream global health actors is going to make a difference in achieving SDG 3 is something I will discuss towards the end of the presentation. We mentioned the importance of leaving no one behind, and that is linked directly with the SDGs. And as Alessia already mentioned, some of the SDGs are refer specifically on disability and inclusion. More work is increasingly done, and the goals on your right, on the right of the slides highlight are those that highlight the most disability and inclusion. Health is not listed there. However, health can be also, discussed within some of these SDGs that are listed here. But we are still far away when we discuss about SDG 3 to we are far away from saying that SDG 3 has a strong component on disability inclusion. We still have to work on that. Now, I'm looking at the time, and we are at 40 minutes, more or less, from the beginning of the discussion. So I will go to a bit discussing about the, let's say, how we can ensure through disability inclusion a better access to health for people with disabilities. And when we talk about disability inclusion or disability inclusive health, we talk about the way we have to follow to ensure or to improve access to health for people with disabilities. But what does it mean, disability inclusion? What does it mean, disability inclusive health? When we talk about disability inclusion and disability inclusive health, we talk, of course, about three fundamental principles: participation, equality and non-discrimination, and accessibility. And I think I have brought here some of the, let's say, some words to define more specifically what these three concepts, three principles mean. But I would like to, knowing that equality and non-discriminations are those that are most familiar, or you may be most familiar with, I would like to focus with you on participation and then refer briefly to accessibility, even if we already discussed about it earlier on. So in relation to participation, this is, what does it mean participation? It means full involvement of boys and girls, women and men of different age groups and with different disabilities in the design, implementation, monitoring, and evaluation of actions and policies that affect people with disabilities. Or not only affect in fact is only, it's a limiting word that relate to people with disabilities, because if we do not work on participation and full involvement, it means that every action that we, for example, want to put in place in relation to health will not see the opinion, the contribution, the participation of people with disabilities, who will be the main beneficiaries, the main users of those services, of those informations. But also it means that when we are going to design an action, no matter if it's a service, is a project, is an advocacy work, we will not know from first hand from persons with disabilities what is needed. And this means that the result may be affected in terms of quality. So when we talk about when we ensure full involvement and participation of people with disabilities, we certainly have organizations that work in a more responsive and effective way, because the decision maker making process is better informed and is fully aware of the perspectives and needs and experiences of people facing the discrimination, facing the barriers. Therefore, this is really essential. And when we talk about accessibility, I already mentioned this before, we have to make sure that we identify the barriers that prevent people with disabilities to access information and services related to health. And knowing that barriers can be different according to the context, according to the type of disability. We can talk about a physical barrier like the ramp, or as you said, attitudinal barriers or financial barriers. And then work hand in hand with representatives of people with disabilities, the BPOs, at different levels to make sure that those barriers can be addressed and eliminated. Accessibility, it is a prerequisite of inclusive health and of ensuring access to health. Now, I will now bring you to look at health. My next step, and one of the concluding steps, is to make sure that you also look at health within the bigger picture. And this slide will help you to identify which are the different elements and the different steps that are necessary when we work towards the elimination of barriers that we just mentioned, and therefore towards an inclusive society that fully allow access to health for all, including people with disabilities. And of course, when we discuss about health, we can have the mainstream services that are already available and need to be made accessible, but we also have the importance of what we call the support services. There are some that listed there, and some specific services. The three elements together and the adaptation and the, of what is already available as mainstream services result into the elimination of barriers and therefore the inclusive society. Knowing that, of course, health is always linked also to all the other elements that we mentioned already. Without proper transportation, access to health is often difficult to obtain. Water and food and sanitation are part of health. Protection is part of our bigger picture of health, that we want to keep it wide and not to limit it. And also employment, meaning access to having an income, being able to pay for services. It's part of how we go and promote access to health. So this is just to summarize a little bit and keep in mind the big picture that within which health is discussed. And again, in this picture also we see the importance of the continuum of care, knowing that not only when we discuss about health, we discuss about going to health services because a person is ill, but knowing that health is also prevention, is early detection, is information and education, it's just in a different picture summarizes the same concept, knowing and making sure that the person, in this case, the person with disability, is at the center of our analysis when we do the needs assessment, when we do the design, when we do the implementation and the monitoring and evaluation, because this is what will keep the quality of our actions high. And again, when we talk about quality and quality criteria, this slide also summarizes the elements that we already have mentioned, that goes from accessibility to adaptability and participation, technical quality, of course, of the services, and non-discrimination. I don't need to repeat it, but having access to these slides may be a good summary of what we have said. I want to show you this because this slide also, because this is also quite essential to make sure that we remember at the end of this presentation, which are the key elements that allowed us to have inclusive health as a real practice, and which is the flow of informations and actions that we usually we are in front of and we contribute to. Because at the bottom we have, at the bottom of this cycle, we have, of course, the users, as we say, people with disabilities, vulnerable population, the DPOs, the Disabled Persons Organization, that have not only the power of advocate for better services, but also are the participants of all the actions, or are supposed to be the participants of all the actions that inform the work of service providers and that request better services and monitor the quality of those services. And at the bottom, of course, we also have the service providers who needs to be put in the condition of doing their work properly when we come and when we request them to be inclusive. So here we go back to the training that we mentioned before. And the exchange of information and exchange of pulling and pushing between these three actors at the policymaker level, at the service provider levels, and at the user level, at the community level, is the interaction that we always have to monitor when we try to promote inclusive health in the best way possible. None of these elements can be taken out if we want to have a full approach to inclusive health. And this, of course, summarizes the fact that all these elements together give us the power to work on inclusive health in a full and comprehensive way. I think I will soon stop talking, and I would love to hear about your questions and about your ideas. But before giving back the floor to you, Alessia, I wanted to give those inputs that I promised at the beginning of the presentation, and saying that today the number of actors actively promoting inclusive health, disability inclusive health, remains limited, is increasing, but remains limited. And DPOs are increasingly work on inclusive health. Disability-focused INGOs like Humanity and Inclusion is on the front line on this topic. And some UN agencies today are also working on it. If you think about the We Decide project of UNFPA, fully focusing on SRH and gender-based violence and sexual and reproductive health for women and girls with disabilities, that is a very nice and good example. Some selected donors have also started promoting work on health, on family planning and on sexual and reproductive health. I can talk more about this if there are questions related to this. Of course, IDDC is on the front line in promoting inclusive health from the advocacy perspective, and I fully contribute to the Inclusive Health Task Group, as Alessia already mentioned. But of course, the members of IDDC are for the majority disability-focused organizations. But then the news is that there are the awareness is raising also among global health actors, global health mainstream organizations that are now looking at inclusive health with more interest as a result of the commitment to leaving no one behind and the SDG 3. And the core group is a platform that also has created a disability inclusive health technical advisory group that promote inclusive health among mainstream organization working on global health. And in this, I can spend a few words on this if some of the people who are attending the webinar is interested to know more. And looking forward to conclude, we said about the lack of gender, age, and disability disaggregated data. Investment on getting more data, collecting more data is essential, need to be supported and need to be encouraged at the country, regional and global level. using at least the 6 questions or the short questionnaire of the Washington group. Again, it is, many of you may already know what the Washington group is, what this short set of questions is about. I'm happy to talk about it a little bit more during the discussion if this is something that you have not been informed of in the past. And looking forward at funds, of course, my recommendation is that if we want to improve our work on inclusive health in the global health measure actions that are currently taking place, it is important to explicitly promoting this in all the calls, in all the actions that donors are promoting today, no matter if they are private or institutional donors. I will stop here, and I look forward to hear from you and to hear your questions. And thank you.
Thank you very much, Alessandra. It really was a really comprehensive illustration of this important topic. Thank you very much. You also introduced so many really crucial elements that it's a pity that our webinar is just 1 hour and a half, because also you started talking about some central concept to arriving to a practical implementation of some tools. So I think that our participants really want to know more about it. So I really invite our participants to make your question in the chat box, or also raising your hand and take the floor and ask directly to Alessandra your question. And I really would like also to encourage the participants just to raising your hands or writing your impression, or just sharing with us some experience that you live in your country at country level. We have already some questions, so don't be shy and take the opportunity and this last half hour that we have to have with us Alessandra. I took some notes about a lot of things that you, the several elements that you shared. So in my, I'm not really an expert about the health topic, so also I should have a lot of questions, but I would like to leave this time to participants. But I really would like to highlight some elements or some barriers or needs, like for example the need to overcome from the charity, medical and social approach to the human rights approach, for example. Another element that really triggered my attention was the lack, or just as you said, the lack of the intersection between gender, disability and health is not well explored. So the lack of data in that case really affect a lot some steps forward. But also, I think that the slides that you share, the last slides you share about mainstream services and from the theory to practices and continuum of care and quality criteria, for us are elements that we really would like to deeper. I know that the time it's not a lot. I'm going quickly to read a couple of questions from the chat box, and I will give you again the floor, Alessandra, to maybe just go through these elements that really triggered our curiosity about the topic. I start reading a question from Florence that just ask, how can we involve government to ensure that persons with disabilities have access to affordable health care? NGOs are doing a lot, but the government seems not to be really concerned. I think that Florence raised an important element, how really we can work in concert with NGOs, with government, supported by OPDs and persons with disability to reach this important goal of access to health. Thanks, Alessandra, to reply.
Thank you. So, of course, when we talk about working with governments, we talk about the importance of, first of all, inform the policymakers. That is our first step. And collecting data that's why collecting data is so essential. So if you, when we talk about governments, of course, we can talk about local governments, we can talk about the country governments, or we can talk about policymakers that have the power to change things. So, but the very first step is to inform them, because we cannot assume that they know what people with disabilities are facing every day when it comes to access to health. And the reason why we cannot assume they know is because the majority of people who are working today as policymakers that have the power are not people with disabilities. And the representation of people with disabilities at the government level in most of the countries in the world is very low, together with the one of women in some countries. So again, as we worked, I would make a parallel between gender and disability because it's so important, and because we really need to bring them together, as you say, Alessia, to build on the experience of already, as we have promoted gender with the different governments, and quite successfully in many countries, and to make sure that women and girls are considered in the work that the governments do. The same it comes with disability. So keep in mind that they may not know, and we need to inform them. This is the first step, and doing advocacy is the very, very first step. And DPOs in this case are the driving force for advocacy at the country level, because they represent people with disabilities, because they can be part of each project that collect those data and be presented at those data to the government. That is certainly the first steps. Of course, then there are opportunities that go beyond the local action that we can do at a country level, and is, for example, the opportunity to attend major events where policymakers are present and need to hear our loud voice. And for example, the meeting that every year, we call it the COSP, the meeting that every year takes place in New York in June, that discuss the achievements at the country level, at the global level, in promoting the Convention on the Rights of Persons with Disabilities, is one of those moments. If we have the opportunity to promote the persons with disabilities at the country level to participate to these events and to speak out in front of those policymakers about what they need and what is important when it comes to access to health, that is also an essential step. I'm saying this because, in fact, this is easy in theory but very difficult in practice, because disabled persons organization lacks funds to not only to do the project at the country level, to collect the data, but also to travel, to go to advocacy events, to have their voice heard. At the same time, we need to support the capacity and build the capacity of persons with disability at the country level and the DPOs to make sure that they become the driving force. Having said this, from the advocacy perspective, we also know that most of the major funds that come through Global Health Project are funds that require the collaboration between international NGOs and local governments and the Minister of Health, for example, when it comes to global health. When we ensure that the calls that are out by donors are disability inclusive and a disability explicitly mentioned, we not only put pressure on the international NGOs to work in a disability inclusive way, but also on the government that becomes the partner, or the Minister of Health that is partner of that project. And that it's another channel, it's another way to make sure that funds is channeled through this project for the service providers training and for the health system strengthening that needs to be disability inclusive, because there is a lot that in these days is done on health system strengthening to make sure that we all have the opportunity to have better health systems in countries for the universal health coverage achievement. But if we miss the opportunity to take disability into the picture when these health system strengthening actions are taking place, then that opportunity is really missed, and that's why we have to work from different directions and in different ways.
Thank you very much, Alessandra. I have several questions about data and also on how to measure, I think, step forward on the inclusion of persons with disability in the health system. For example, Amberle from World Relief asked, regarding the data discussion, do you have suggestion for standard outcome indicators that mainstream organizations should use in inclusive health project? But also Raya asked on how we can measure the accessibility to inclusive health rights. So I think that on the basis of this question, but also of this work, there is always, in my understood, the same issues, so the lack of data and this lack of intersection about disability and health data. Thank you, Alessandra, to give us your point of view about it.
Yes, thank you for the question. And creating indicators that can be used is part of the process of promoting inclusive health, because as you mentioned, data disaggregation and collection specifically on disability and health is limited, and little work has been done so far to really create proper indicators that serve this purpose. So going back to the idea that I mentioned on partnership that earlier on, so much work has been done on global health and indicators to monitor and to measure the quality of services and the quality of work done on global health. The experience of global health is huge, of the global health actors is huge. However, they lack the experience of working in the field of disability. On the other hand, the work done on disability is also extremely relevant. However, for so many reasons, measuring access to health for people with disabilities has never been a focus that has been pushed when it comes to indicators per se. So the answer I could give and the direction that I would recommend is to work in partnership to put together the capacity and the strength of both fields to finally translate into practice what we mean with disability inclusive health. And this is something that really needs to be encouraged, and that, for example, in my work, I'm involved daily. And of course, when it comes to data and to indicators and to the collection of data, is essential, but the distribution, the sharing the data then is also an essential point, which are the areas where we can and the context where the data needs to be shared and how. But I'm happy to further discuss about this, maybe also beyond this webinar, on working on indicators for on health and disability, because this is really a crucial point.
Thank you very much, Alessandra. I have a question from Maleku Zengeta. I really don't understand your question. If you want, you can raise your hand and take the floor and just explain better your thoughts. about it. I'm going ahead with a question again from Raya, and I think that it's a curiosity of everybody. If you really, in the last 10 minutes that we have, if you can share really some successful experience in the facility of the health rights. Some experience also from my side. I would like also to ask on how really improve the exchange of information and really putting in connection all the key actors to improve on it. Thank you very much, Alessandra.
Thank you for this question. I'm happy to share. So having said that work on inclusive health is promoted, but we don't have a long history of monitoring and accessing the results of it, I choose to answer to you, sharing with you an experience I am fully involved in that is a promising experience when it comes to inclusive health. One of the major donors that today is promoting inclusive health more than others, many of you may be aware, is DFID. And DFID has launched several calls and several opportunities to promote sexual and reproductive health and rights around the world. One of them was a global call called Women Integrated Sexual Health. It is a call that came out 2 years ago and that now finally sees the implementers of the project that have been receiving these funds in the process of really putting together forces to make sure that that global health action is an inclusive health action. This is the example, and HI is part of it, so I'm able to talk from experience. The request, the objective is to improve sexual and reproductive health of overall population and the most difficult to reach around the world. The project I'm involved in is covering 7 countries. I know that some colleagues from Ethiopia may be on the line, and Ethiopia is one of the countries where the Women Integrated Sexual Health Program is going to be implemented. And this program is an example of how mainstream organizations and disability-focused organizations and DPOs join forces to ensure that this global action on sexual and reproductive health of many millions of pounds will be disability inclusive. 3 different mainstream INGOs working regularly on sexual and reproductive health and HI have joined forces specifically to ensure this inclusiveness of this project, and they will work in the following way. HI will be the technical partner that will ensure inclusiveness on one hand by training our mainstream partners of what disability and inclusion means, because they need to be fully aware, but also will be working with the DPOs, the Disabled Persons Organization at the community level to raise the awareness of the community, of the public at the community level to share and to make sure that people know that people with disabilities are subjects of sexual rights as everybody else, and also to create a demand for sexual and reproductive health services that has been frustrated for so long, so much that people with disabilities stop to go to SRH clinics in many countries. Also, we work at the community level to collect those data that are important to identify the needs of people with disabilities, and then those needs will be the base to design and implement the project. HI is also the technical partner that support the service providers and train the service providers to make sure they are aware of which are the barriers at their services and which is the way to follow to make sure that their services become disability inclusive and support the entire action throughout the project, and support the advocacy process to make sure that those information we have collected at the community level, those information that we have collected at the service provision level when the project is implemented and the services are offered, can become an important food for advocacy with the policymakers. So this is really translated in the language of SRH. The example of how a global health action that it's a classic global health action on SRH can be fully translated in SRH. The project has not started yet, it's starting now. It will be at least a 4 years program that will, as I said, will cover 7 countries. And I will be happy to update those who are interested in the progress of the program to make sure that we can, of course, lesson learned will be collected and will be shared so that more can be learned from this experience, because we are far away from knowing what works and what doesn't work. And so we are exposed to opportunities for learning, but also a risk of facing challenges that needs to be addressed.
Thank you very much, Alessandra. I would like to give the floor really quickly to Maleku to explain better the question about training services about sign language of interpreters. So a really specific question. I open you the mic, Maleku. If you want to talk now, you can. Thank you.
Thank you so much, Alessandra, for the excellent presentation. My name is Malaku from the Ethiopian Center for Disability and Development. Inclusive health services is also one of our priorities. Mostly when we implement programs, we see differences, like competing arguments. One, on the service providers, people say training service providers in sign language would bridge the communication gap between deaf clients and the service providers. On the other side, people say no, since this is a very sensitive thing, without, we don't have to compromise the level of communication, so we have to hire sign language interpreters. Is there any literature, is there any experience, which would resolve these two competing arguments globally? Thank you so much.
Thank you very much, Maleku.
Thank you for your question. If there is literature available, I'm not at the moment aware of how to, what is the literature promoting, but I can certainly have a look and maybe we can exchange on this topic. And I could also ask among other colleagues who have been involved on this topic to see if we can find a good answer. But you certainly touch upon a very important topic, that is how to guarantee for people with disabilities, in this case, people with hearing disabilities, the privacy and independence on when they go and access and ask for services. And it is one of those elements that come with the respect and dignity for the person with disability, but also to make sure they can be independent. Because just to extend a little bit your question and to share something that may be relevant for everybody, sometimes we see people with hearing impairments arriving at the services accompanied by a family member, but we cannot assume that the person can always be fully protected in the rights to access health, being accompanied by a family member. And sometimes the family members are very protective, sometimes take decision instead in place of the person with disabilities, thinking they are they are doing it in the best of interest of the person with disabilities. But in reality, by creating filters and barriers, we create, limit the autonomy and the full independence of person with disability when it comes to access to health. So having said that, I can look into the literature to better answer your question. I would say that the core element here is to make sure that the best of service is guaranteed for the person herself or himself.
Well, thank you very much, Alessandra. Unfortunately, I have to say that we arrive at the end also of this session. I don't know for the others, but for me, really the time fly up a lot because it was really interesting. A lot of really important elements I think we shared today for this topic. So thank you very much again. Alessandra, for your participation and your contribution, and for having dedicated your time to us to bridge the gap today. I also would like to say thanks to all the audience, to all our participants that really follow us constantly. I really hope that you find also this session useful for your work. So as you know, the webinar cycle is composed by 12 sessions. So we missed just the last 3 sessions, the one on advocacy and programs at local level, another about women and disability, and the last one, social protection and livelihoods. We will provide the last 3 sessions after the summer break, so it means September, October, and November 2019. We will come back to you soon with further information about this last 3 sessions with dates and time. So for the moment, again, thank you very much to everybody, to all our followers, and to Alessandra for your contribution and to share your experience with us. Don't stop following us. I say that to our audience, but also to Alessandra and to all the experts that we are involving in our action. So thanks again to everybody. Enjoy the rest of the day, and for whom is going to have holidays, also the Easter break. Thank you, Alessandra, again. Thank you to everybody.
Thank you all. Thank you, Alessia.